Okay, so today we're going to talk about the use of microarray in obstetrics. And this topic was brought about by Dr. Groom because he wanted us to kind of explore some of the more basic kind of biochemistry, molecular biology topics that we don't really think about a whole lot, but that, you know, we use this technology for our patients. So hopefully by the end of this you'll understand what microarray is and be able to talk about the advantages and disadvantages and really be able to compare it to different techniques that we use to look at genetic material. Also use some of this information to be able to counsel your patient on the possible results and things like that. So when we talk about analyzing genetic material, there are a couple different ways that we can do this. So classically, we do it through karyotype and then followed by fluorescence in situ hybridization or FISH. And then now we have this newer technology called chromosomal microarray. So if we're going to talk about that, we kind of have to go back to the basics of genetics, right? And so that all starts with DNA that gets turned into RNA via transcription, which then gets turned into protein via translation, and that's kind of our gene expression, right, because of that. So remember that this was all brought about back in like 1958 by Dr. Francis Crick, right? This is what we call as the central dogma of molecular biology. So remember, it's this process and some of these materials that we're looking at when we're looking at genetics. So we're looking at DNA, right, like we said before. Remember that there are two polymerized strands that we see. They have 4 different bases, as we all kind of remember this from way back, even pre-med school days. Okay, so when we talk about genetics, right, as far as the human genome, there's 300 billion base pairs of DNA that are organized into 23 chromosomes. And those are really the basis of what we look at when we're looking at the genetic material. So remember that as humans, we're known as diploid organisms, right? Meaning that we have 2 sets of 23 chromosomes, each derived from 1 set from each parent, okay? And so technically the gold standard right now is karyotype, right? This is something that we're all familiar with, that we learned in biology, how we look at the chromosomes. And what we do is we look at a metaphase karyotype, right? So remember that metaphase is one of the phases during mitosis, right? Mitosis is where you have 1 cell that's splitting into 2 identical daughter cells. And so in the metaphase, right, the chromosomes condense, and this is where they're maximally condensed. So you're able to see their banding patterns the best at this point. And so this is the point where we get a karyotype. So you have to have a dividing cell in order to do a karyotype, and you have to freeze it in this metaphase state. Then they put it out in this chromosome, right, and you analyze both the structure and the banding, and it kind of gives us a hint as to what the abnormalities may be. So as far as the banding techniques, remember that it's a GTG banding. So it's a G banding with trypsin and GEMSA banding. That's the procedure that they do with the karyotype. So as far as the karyotype, we can only really detect major structural abnormalities, and it really is hard for us to find like smaller areas of deletions or duplications with a karyotype. Okay? But one of the other advantages is that you can do the entire genome and you can see some specific anomalies. But remember, like I said, it really only does major structural things. It requires a dividing cell. And this procedure itself, because you have to grow out the cell, it takes longer. It takes about 1 to 2 weeks for you to grow out the cells and then analyze them. And it's very labor intensive and dependent on the person that actually performs the procedure. Okay? So the other method, FISH, this is another method that we can look and analyze genetic material, right? So with FISH, you have to fix the DNA onto slides here. And then what happens is that you have these probes that are looking at specific areas in the DNA. So you have to make these probes to look at specific areas. The probes then are usually attached to some kind of fluorescence via an antibody so that then they can be analyzed and that you can see the area that you're looking at, okay? So this is what a FISH looks like. On this slide, this is an example of a patient that has DeGeorge syndrome. So there's 2 markers. One of the markers is these 2 green dots. So that's going to indicate to you that you're looking at chromosome 22. And then this other marker here, this red band, that's where the gene would normally be, right? But here you don't see it here, so that's where there's that microdeletion in the patient with DiGeorge syndrome. Okay, so as far as FISH, it does have better resolution than the chromosome. So you can look at smaller things versus those larger structural abnormalities. So with chromosome banding, the minimum is about 6 megabases, and with FISH, it's about 2 megabases. So you do have higher resolution with the FISH. And with FISH, it can be applied to both dividing and non-dividing cells, but typically it's used at the same cells, those metaphase cells that we use in a karyotype. Let's see. So as far as what it can identify, not only can it identify big structural abnormalities, but it can identify deletions, duplications, aneuploidy, and it could even do some rearrangements and some of these micro deletions that we see. So as far as the disadvantages, one is that you really can't define less than 2 megabases, right? So you can't really find those small point mutations or inversions, and it really doesn't do an inversion, or uniparental disomy, right? Remember that that's when all the chromosomes come from one parent for that person. And you have to have the person that's ordering the test has to be suspicious and choose the right probe in order to look for that abnormality. So now we move on to chromosomal microarray, which is a relatively new technology as far as looking at genetic material. And it was discovered in 1991, and the technique from this comes actually from computer chip manufacturing. And so in 2004, the FDA did approve it for medical use. And so we're going to talk about these chips that we use. So these microarray chips, they have dozens to millions of molecules on the surface, meaning that it can test a bunch of different things at one time. Okay, so that's one of the biggest benefits to a test like this. And what it does is it compares your patient's DNA to a normal control individual, okay? And what it can do is it can detect, again, aneuploidies, it can detect large structural changes, but now it can also detect submicroscopic duplications, deletions, and unbalanced rearrangements. So how is this performed? Well, you need to have a sample, right? And the sample that you need is going to be the fetal cells. So from this, you can get it from chorionic villus sampling, cord blood, or amniocentesis. Unfortunately, you cannot do this procedure on cell-free DNA because in order to amplify it, it would then amplify not only the fetal cells, but also the maternal cells, and then that would drown out the fetal cells. So it can't be done with fetal cell DNA. So once you get your tissue, then you have to isolate the RNA, and that's done using solvents, vortex, and centrifuge, and then you're going to isolate your RNA. And from that, then you have to isolate your mRNA. So remember, your mRNA is what then gets translated into the protein. So as far as the mRNA, remember that they have these poly A tails, so you can use that to isolate them. So you have these beads that you're going to wash them through, and the poly T tails on the beads are going to attract the poly A tails, so you can isolate just that subset of RNA, okay? Then after that, now you want to go back and make it back into DNA, okay? Because that's what you're going to put onto the little chips. So you use a reverse transcriptase, and you also use some label nucleotides so that you can see the different DNA, right? So you go back from RNA, you go back to DNA. And so you can see here that your control cells then have one colored label, and that your patient cells have another colored label. So after that, then now you're ready to apply these DNA to your microarray chip. Okay, so you're going to let it hybridize, and then you're going to wash off the excess DNA that didn't hybridize with anything on the chip. So now what you have to do is now we have to get the data and we have to analyze it. So in order to get the data, you actually have to have a machine that scans the little chip and kind of gives you some information. So what it's looking at is going to look at the different frequencies and kind of shows you different colors, okay? And so that's what you're going to have to analyze once you get it back. And so this is an example of what you might see. So what they're doing is when you do that and it's comparing the control DNA to your DNA, it's looking for different copy number variants, right? And so if they have the same copy number variants, then it's going to be here right at this line. But then if it has more than it should, then it's going to have a spike like it does here. Okay, so the basis for microarray is this comparative genomic hybridization, right? So it's a method where we can look at deletions or duplications and you're comparing it to a normal sample. You're looking for either an overrepresentation or greater than what you have or less than what the normal is, okay? And as far as microarrays, there are different types. There are some that are targeted, meaning that they look at certain sections of the genome and test for only those certain sections. And there's whole genome arrays which can test the whole genome, but obviously there's downsides to that, right? So when we have a whole genome array, one of the biggest downsides is that because not all of these deletions and duplications are classified, meaning that we don't really know if there is any effect as far as disease producing or if it changes the phenotype or anything, those whole genome arrays can have a lot of data that is uncertain. And that makes it hard for us to talk to our patients about and counsel them as far as what they can expect with the result that we get back. So there are some databases that are currently collecting data, and as we use it more, are putting all these deletions and duplications and abnormalities they see, and if there's some kind of phenotypic link, then they'll put them in all these databases so that other people, if they should come up with this, have somewhere to look as a reference. There's also some other genome browsers. They're kind of doing the same thing to try to figure out where we can put all of these results that we're finding. So again, the advantages of chromosomal microarray, it's even better as far as your diagnostic yield, right? You can have even a smaller portion than you needed with fish, okay? So if you're comparing this to karyotype, you're looking at 50 to 20,000 base pairs versus 3 to 10 million base pairs in a karyotype. So you can get a much smaller sample that you need to get a result. Again, it's also a faster result because this is an automated thing. It goes through you scan the machine and then you get this data, okay? So it's not a process where somebody actually has to do it themselves and look at it. You don't have to grow out the culture, things like that. So you can get results as fast as a day versus 1 to 2 weeks with your karyotype. So as far as the disadvantages, remember because it's looking at these copy number variants, it's not able to detect anything that would be considered a balanced arrangement, right? So it has to be something that's unbalanced that it can detect. It also has a very poor ability to detect triploidy. Remember, because especially even in that setting, the gene content is relatively balanced. But one of the things that they talk about as far as triploidy, luckily it's pretty rare and it's usually suspected based on other findings on ultrasound. It has a variable ability to detect some mosaicism. Remember, like we said before, it does produce massive amounts of data, and sometimes you don't know what to do with the data. And again, there's these variants of undetermined significance, meaning that they have an abnormal result from this microarray, but nobody's really sure if it's attached to a disease or a specific phenotype that would need further exploration. And as far as expense, it is expensive as far as the startup. You need to have the machine, you need to have somebody that's able to prepare the specimen. The chips itself are at least a couple $100s, so, and you can only use each chip one time. So this is a study where they looked at patients that underwent invasive prenatal testing, had a normal karyotype, and then they used a microarray for those patients that had the normal karyotype. What they found was that there were 36 patients out of their 254 that had an abnormal microarray. Okay, so that's about 13% of the patients that they looked at. Then they also looked at, when they looked at the abnormal results in the microarray, they looked at those that they would consider benign, and then those that were probably abnormal and that would be of clinical significance. So of those 33, only 3 of those are what they would consider abnormal and clinically significant. So that was 1.1%. And in this table, what they did was they compared it to some other studies that looked at the same thing. So, out of all these studies, 1, 2, 3, 4, 5 studies, they said that as far as having a normal karyotype and then testing with microarray, the percentage of those that then were abnormal is anywhere between about 7.9 to 13.3%. And then of that, those that are considered to be clinically significant are about 0.7 to 2.7%. So as far as this article, they concluded that the use of CGH or chromosomal microarray does add significant value to the evaluation of some of these low-risk and high-risk patients, but that they needed further studies to detect if this really should be a first-line test in prenatal screening. So this top study, that's the one that we just looked at, and then I found another study, and this one, what they did was they wanted to implement and validate whole genome testing and genetic counseling for prenatal diagnosis. And so what these people found is that after their normal karyotype, they had about 6.5% that were clinically relevant. And so this just goes to show you that this is another study that would fit into those other 4 that we saw that were in comparison, that the data is about the same of what we can find in addition when we use a chromosomal microarray. So this is one of the really large studies looking at chromosomal microarray. It is a very large prospective study done in 29 centers looking again at standard karyotyping and chromosomal microarray. So this, as you can see, has a very large patient population, right? Over 4,000 patients. Well, when they looked at the microarrays, 4,282 samples, they found that this identified all aneuploidies and all of the unbalanced rearrangements. Then they looked at the normal karyotype samples and compared it to the ones that when they did the microarray, there was something clinically significant. And so they found some deletions and duplications in 6% and with a structural anomaly, and then 1.7 in AMA or a positive screen. So saying that even with a normal karyotype, if they had something else, they had a better detection rate with the microarray. Okay, so that's pretty much what we just talked about. Okay, so now that we kind of learned a little bit about the testing, now it's like, okay, well, what do we do with this? How do we use this in our clinical practice? Well, so ACOG and the Society for Maternal Fetal Medicine does have some recommendations on the use of microarray for prenatal diagnosis and for fetal demises. Okay, so we should definitely use them in those settings. And one of the things is, besides those settings with the congenital anomalies or the demise, if you have a patient that's undergoing invasive prenatal testing for some other reason, that it still could be offered to them because you're not doing anything more in addition to getting their sample like you normally would. So this is another situation where you could offer it to your patient. They have no current recommendations about using microarray in early pregnancy losses, like first and early second trimester losses. And then this list here, IUGR, increased nucleotranslucency, abnormal maternal serum screening, soft markers or oligo or poly, they could also be offered microarray. So when we talk about fetal demises or stillborns, when we look at the genetics of these fetuses, 5% of them that are structurally normal will have some kind of abnormal karyotype. And if they are structurally abnormal or macerated, 35 to 40% of them have an abnormal karyotype. And so when we talk about that, often it's very hard. I know a lot of us have tried to get tissue from these babies, and when we send it to the lab, they're not able to grow out the material. And so, the tissue culture success for them to be able to do like a normal karyotype is only about 50%. And so microarray could add a little bit to this. So these are some studies looking at medically terminated or stillbirth fetuses. And in the first study, it was looking at fetuses with 3 or more significant anomalies in a normal karyotype. So what they found is that in 10.2%, of this population with microarray, that they had something else going on. And the bottom one also shows that with, as far as genetic material with the yield versus a karyotype versus a microarray, you had 87.4% was able to yield a result with the microarray versus only 74 with a karyotype. And some of the things that these 2 articles brought up was that, you know, some of these things that we find with genetic analysis is very important, especially to the parents, because if they're a carrier of something, it could really affect their future childbearing. And so it could be used to counsel them and help them through that process. The other problem is that, remember, because there's so many variants of unknown significance, that if you find one of those, then that makes it harder to counsel them, to figure out how you should counsel them on that. So it creates a big uncertainty issue. So it's good for it, but then it's also bad. So while most of the time we only see the patients, you know, while they're pregnant or if they have a fetal demise, this testing is also used postnatally, okay? So they use it in children that have an unexplained developmental delay, anybody that's kind of on an autism spectrum disorder, and anybody that has multiple congenital anomalies that can't be grouped into a specific syndrome. And so there are other implications for microarray testing. So one of the biggest things, obviously, that you can see is going to be the counseling. How do you counsel your patient on what can happen, you know, with the microarray testing, what it is, what kind of results can you get, etc. So they do require that when you offer microarray testing to a patient that they have not only comprehensive pre-test, but also post-test genetic counseling, and that they do sign an informed consent for this procedure. And you really should document your discussion with the patient, right? So number one, you need to really document that this is not going to identify all of the genetic abnormalities or diseases that is out there, okay? So it does have a limitation. Not only that, but there are findings, like we said, that are uncertain, nobody really knows what it means, and so they have to get that. There may be a result, and we may not be able to tell them what this means. Through the testing, they could also discover non-paternity or consanguinity, and it could also show some adult onset diseases, right? So like BRCA, things like that. And so that's going to be something that they're going to have to figure out what to do with that information should that become positive. So ACOG actually has a committee opinion. It's number 581, and it's the use of chromosomal microarray analysis in prenatal diagnosis. And one of the best things in this committee opinion is this little box here, and it tells you specifically how to counsel your patient and what specific things should be addressed when you counsel your patient. So we already talked about most of these, right? It doesn't identify all the genetic disorders. Oh, remember that even if you find a specific disease, that a lot of diseases have a variation in the phenotype. And so oftentimes you're not going to be able to judge the severity or the phenotype of these patients with this disease. And for some people, that's very hard to grasp that concept. So you need to kind of explain that to them. We already talked about the consanguinity, the non-paternity, the undetermined significance, and then the adult onset diseases. Okay. So this is a study looking at some of the women that received, that got results of their microarray and kind of some of their responses to these results. And so this study is good to kind of look at so that when you counsel them, kind of know how you can support your patient and really have a good conversation with your patient. So after they got these abnormal results, these were the major themes that these women kind of brought up in their talk. So one is that they felt that this offer was too good to pass up. Like I said before, they were already decided to have this invasive prenatal testing, and so they figured, well, they're already going to stick a needle in me. It's not really I'm not going to have to do anything else, so I'll just go ahead and get this test. So that was one of the things that they felt. Then another was that they felt that they were blindsided by the results, meaning that they got their karyotype results before they got their microarray results, And so their karyotype was normal, and then when they got their microarray results that were abnormal, they didn't really know what to do, and they had already thought that everything was okay. Again, that uncertainty and that unquantifiable risk, so they just felt really confused and overwhelmed with that kind of whole picture. They really stressed that they needed support, so not only support pre-test, but post-test, especially managing kind of, their feelings and what they thought was going on. And they felt that they needed support and help with if they were going to proceed with any kind of, if they were going to act on any of those results. And then the other theme was toxic knowledge. So they felt that they needed more counseling on the fact that some of these results were going to be uninterpretable and that they were going to be uncertain. And, then those results, when they got them and they were abnormal or uncertain, then those patients then started to look at themselves and say, is something wrong with me? Do I need to be tested? And so then it put a lot of uncertainty in that area. So, so these, again, this are some of the factors that we need to take into consideration, that there's some anxiety with this kind of testing, especially if, your patient knows that there's something structurally wrong on an ultrasound or they have an abnormal serum screen. Then there's a lot of anxiety when you're doing these confirmatory tests. And that, you need to talk to your patient that there are some options if there is some abnormality discovered, okay? So then that kind of leads the talk into kind of your patient's social and moral values about what they would do, how they view abortion, how they view, parenting a child that may have a disability or a lifelong disease. So as far as the follow-up, multiple contacts should be done with the patient, okay, and the couple if available. So not only pre-test, not only one post-test, but multiple and repeated contacts with the patient to make sure that they fully understand, that if they have any questions, if they need any additional support, to try to get them through this process. If they desire termination, there should be some assistance in heading that way. If, they desire to continue with the pregnancy, again, reassessment with making sure that they're okay with the situation, making sure that they have a plan for after birth, for care of the baby, things like that, and referring them to support groups, online support groups in the local network, especially with those that have, are in a similar situation. So this is one of the resources that you can refer your patients to. And, here they do have some online support groups and just some good information as far as these kind of more rare disorders that they find. So as far as what do we think is going to happen with these microarrays? Well, in the future, this could be one of the rapid assessments for prenatal diagnosis, and it could be used also in newborn screening, and it could give us, better information than we have now. But not only can it be used in prenatal testing, but it can be used in other areas of healthcare. So one, it could look at different viral loads and virulence factors of different viruses, and it could even characterize some malignant lesions. So when I was covering the clinic, I did come across a patient that did get a microarray. So this patient had a fetus that had a bilateral cleft lip and cleft palate. So she underwent amnio, right? She got her karyotype and she got her FISH, which were both negative. So then she was offered a microarray. They got the microarray and she had this deletion, which they determined to be of undetermined significance. So, right? So this is one of those examples where their patient, there's something structurally wrong with the fetus, but they have this deletion and they don't really know what happened. So this is like a real life example of some of the things we just talked about. This is what the results would look like if you're looking in Epic. It does come up, I think, under the media section. So CombiMatrix is the company that we currently use to do the microarrays. And so you can see here, this is how it's reported here as far as what the findings were. So if you go to the CombiMatrix website, they do have information not only for patients, but also providers. So this here is kind of this first page in this handout, and it just talks about like what is a microarray, and it talks about what types of results are there, why is it being offered to me, etc. Then the other thing that you can also find on their website is actually what the test tests for. So this test that we use is a targeted array, and it has a lot of different things that it tests for. So you can go on the website and actually look up to see what's on the little chip that they use and all that. And that's it. I have no idea. I think that a lot of them are, if their karyotype and fish come back negative, then they get offered that. But I don't know, maybe Dr. Groom can add. Mm-hmm.
We counsel them regarding it. It's all dictated by what we see on ultrasound.
Question. A couple comments. How much does it cost? Who pays for it?
I have no idea.
I can tell you it's $1,200 to $1,400 for a microarray, Suzanne Urson told me that, which is cheaper than many of the specific gene testings, which cost $3,000 to $3,500. So it's kind of a bargain. The problem is Medicaid won't pay for it. A lot of insurance won't pay for it. The hospital eats the cost for most of them that are done in-house. You know, it's part of that, you know, we're stuck with every time you turn around saying, oh, you must be doing genomic medicine. That's the state of the art. You have to do genomics, but nobody will pay for it. Two other comments is there's not enough geneticists in the country to counsel people with abnormal microarrays. I mean, our, you know, the wait for our geneticist now is 9 to 12 months for an appointment. And because she's getting inundated about all these genetic things that somebody wants her to take care of and counsel, and they don't even have to do anything with common clinical symptoms. The last thing, I bet the lawyers love this. They see bukus of abnormal testing, I can sue you. Normal testing, I can sue you. Oh, you invaded their privacy by indicating consanguinity to this lady, and now the whole family is suing you. So I think that you didn't mention anything about the legality of the testing, but I think there's a lot of potential legal ramifications here from psychological trauma that's created by questionable testing. And that's one of the biggest things I've seen about microarray that has been cautioned. There's so many things that nobody knows what it means. It creates lots of stress and anxiety among the people that are getting it.
Echo what Dr. Keel said. I mean, we see a significant proportion that comes back with uncertain clinical significance. So all I can do is speak for myself. I try to use it sparingly. If you have an obvious abnormality that's just the baby's not going to survive, then I see no value in really doing this myself. That's just speaking for myself.
Like any test that's in its infancy, it's going to be very powerful once they define it better later on. Just like
Do you see patients asking for it?
No, not really. No, it's something we offer them under well-defined circumstances. We're more apt to freely use cell-free DNA. I mean, it's almost if they have a baby, some way they end up getting offered that. So, I agree with Dr. Keel. We need to be judicious with our use of testing. I think Dr. Morgan has a question. That was very good,
He
Jodie.
doesn't
Thank you.
know. He doesn't know.
He wants to know what metaphase is.
What?
Wants to know what DNA is.
Well, you know, it was a long time since some of us looked at that kind of stuff. I'm just saying.
That was very good, Jodie.
Right.
Very good.